So there are not too many questions here. So I might start. Noreen, so this is ctDNA as a diagnostic tool in the absence of histology, effectively. What you're trying to do, is that right?
It's a bit more than that. So we've added it to the diagnostic pathway. So we're not saying don't do an invasive diagnostic test. So it's been added to the pathway as is, but it offers opportunities under a research protocol to treat without tissue for those patients who are stuck. So stuck without conclusive biopsies, stuck because they can't get into the pathway because of comorbidities.
I mean, the number of times I've been stuck. So the obvious sequitur to this is that, that is going to be the proposed outcome, isn't it? And you can see there's the ground just shifting slightly here, can't you? Impossible biopsy, very difficult biopsy. Let's just use the liquid biopsy. I mean, isn't that going to happen?
I think so, and I think it's important to generate the evidence and understand the context and the infrastructure that you need to create around that to have that diagnostic or clinical confidence. So it's not in isolation, it's all part of the MDT and drawing in the MTB. But I would also say the other aspect, the efficiency of the 2-for-1 molecular profiling, and supportive of the diagnosis. It brings molecular profiling right up front at the point of diagnosis, and I think that will have a tremendous benefit in terms of driving the precision approaches that Juan mentioned earlier. What I forgot to sort of pull out was that even in the 50 patients where we've looked at the data, 1 in 5 had an actionable aberration.
Absolutely. Which brings me to the second question about that. Are you happy with Guardant? Are you happy with the technology of the liquid biopsy?
I think so. I think I would go back to no diagnostic test, including tissue, is 100% perfect. So I think, my take home is that 15% of the time tissue doesn't pick up something that liquid would, and vice versa. I think probably for the fusions, so the NTRK fusions, which are very uncommon, but for the fusions, and maybe for BRCA, I think the liquid biopsy test may not be as sensitive as the tissue testing.
I mean, in some ways, you're going to be lucky there, aren't you? Because the difficult biopsies are going to be the hilar tumours, which are generally speaking fusion negative. So that very much plays out. That was a stroke of luck, if you like. Professor Primrose has got a question.
So yes, unsurprisingly, I agree completely with Hassan in his assessment of where clinical services should be. Just want to raise the issue of ERCP, which I think is pretty controversial. And Chris, I think, has been quite candid about the problems, although I think they're actually worse than he indicates. I think in surgery we have had specialisation in large units with complex upper GI surgery for a long time now. And I think in ERCP, it's 20 years behind when this should have been done. And I look forward to, although with some scepticism, developments going forward. The point to emphasise, I think from my perspective, is that ERCP for hilar cholangiocarcinoma is a massive, a quantum difference from standard diagnostic and therapeutic ERCP. And he'll be horrified to hear this, but we have expert ERCPists in our unit, and I don't let them at hilar cholangiocarcinoma unless it's a bismuth 1, that is, and a single plastic stent up the middle, because it can, Hassan may not agree with me, but metal stents totally screw up the surgical field in terms of doing radical resections. So I think there is a lot that needs to be done there, and certainly what Chris outlined in terms of specialist centres is absolutely the way to go, but it really needs to be done now.
Shall I respond to that? Or?
Yes.
Because I think I was candid, but obviously I didn't want to labour the point too much, but I absolutely agree with what you said. And I think I didn't have time in my talk today, but again, management of hyalocholangiocarcinoma is often best done percutaneously by the radiologists with PTC, and we manage a lot of our hyla cases in that way, or with plastic stents. In palliative management, we would typically favour bilateral metal stents with hyalocholangiocarcinoma, but certainly not if curative resection is either proposed or plausibly possible. So yeah, I agree with those further comments.
Thank you. Oh,
Question. Firstly, it relates to nearly everybody, sorry. The first thing is that in relation to the liquid biopsies, I congratulate you, because I, for one, have had many biopsies, and I was under my primary unknown cancer was unknown for quite a while, until it was sent to the Christie, I believe, who diagnosed and found out that I had bile duct cancer, and I could have benefited from that, I believe. So yeah, that's great. The second thing is I'd like to say thank you to Dr. Wadsworth, because I truly believe that if he hadn't have seen me, I wouldn't be standing here today. So I truly wish to thank you for that. I will be eternally grateful. But the other question I have is around ERCPs. I have been stented probably quite a few times, and I would like to know how many times can you be stented, and also is there anything, and it's probably a really silly question, but is there anything being done in relation to stents, metal stents? I have a metal stent. What is being done in relation to durability? Because from what I was told when I was inserted, that they last for about 3 years, and if you can only be stented a certain amount of time, are we not working on the durability of those stents? Because I, for one, feel like I'm being attacked in two ways. One way by the cancer, and definitely I'm in favour of the stenting. So yeah, that would be my question. Thank you.
So thanks very much for the comments. I mean, obviously it's very hard to talk about an individual case in a meeting like this, but there isn't any arbitrary limit on the number of stents that a patient can have. But it does depend very much on the specific circumstances, because if a removable metal stent or a plastic stent's been placed, that could be removed and replaced innumerable times. With bare metal stents, I talked about, once they've been in there for a few days, you can't remove them, and they cause quite an intense inflammatory change within the bile duct. So they're not removable, but there are things you can do. You can stent within stents, you can put new stents in, and you tend to try and put a removable stent through the unremovable stent, so then you don't start getting a diminishing lumen, so a diminishing diameter of stent. And there are things you can do to open block stents, so you can do RFA ablation of tissue that's grown into the stent to open it up again. So though that's a relatively new development I've talked about before here at this meeting, that, if you like, prolongs or maintains the patency of stents without requiring them to be replaced. There has been work done on attaching chemotherapy agents to stents, paclitaxel and so on, which unfortunately didn't really show much benefit, and also attaching antibiotics to stents to see whether that reduced stent infection and stent blockage, but unfortunately didn't work. So the manufacturers certainly constantly producing new iterations of their stents, but I haven't seen, and I'm not aware of any imminent major sort of technological breakthrough in that regard.
thank you. Now we have several questions coming in. Once again, the topic is the liquid biopsy. Some of them we have already addressed, but one is important, I think, how best can a patient access Guardant? So, because here is, I struggled by trying to ask the company directly, that I don't think it's the best way to do for the patients. Probably doctors should ask for the test or...
Yeah, I think so. So I think in this specific, in the Access programme, obviously that is within the innovation programme. I think in terms of, particularly if patients are struggling to have a molecular profile through tissue, I certainly do talk to my patients about the liquid. It's not just Guardant, there are other companies, but I certainly talk about there is an ability to do that. It is through self-fund currently, but I think it is part of a conversation in terms of people want to know the options and how they might themselves access these technologies.
And just to add to that, to be fair, Guardant have a number of programs where you can be part of a screening program and consequently access the Guardant test free of charge. So there's that as well. But these are not obvious to the sort of uneducated observer, and do need a bit of work. And I think perhaps some a bit more transparency around that would be very helpful. Yeah.
Yeah, and I think also, we talked about the genomic laboratory hubs earlier. There is definitely, liquid biopsies are part of the National Cancer Strategy. If Peter Johnson were here, he would say that as well. And it's about developing the evidence. So they're starting with lung in terms of a blood first, tissue second strategy with a national service evaluation. And, we're all throwing our caps in the ring for that, because I think across a number of the cancers we treat, that's probably the way to go in terms of equity of access.
There is a question about the referral centers or specialist centers. If referrals to specialist centers happen as they should, are there enough resources available, or do other problems at that point arise?
So I think what's important is to ensure that there's a good standard of care across all the centres, because the flip side of pulling resources, because that's what you're going to have to do, to a centre from other sites, is that can compromise the quality of care at those other centres. And that may not just be financial, but it may be a brain drain. It may be that clinicians don't want to continue to work there. So there is that element that has to be looked at. But ultimately, it should be around providing sufficient capacity to treat the patients in a timely manner. And certainly if you're looking at surgical options or transplant options, that is especially time critical. So yes, those resources will have to be found if there is a national discussion and debate in that direction. But that hasn't started.
So there's a question here, and I think it's for both of you two really. It says, what is the biggest obstacle / challenge to development of centres of expertise? The biggest, just one. Perhaps you could start, Hassan.
I think, I think you can't, it's not a single word answer. I think you need to bring everyone together. That's the key thing. It's interesting that it's happened in Holland because there's a smaller community and you've been able to do that. There's also this concept of surgical oncology. So, liver surgery is being done across different types of models. So certainly for the UK, it's about bringing that clinical community together with a single purpose. And ideally, and I might be a bit, stupid here, but that single purpose is all about the patient. So as long as we can bring it back to that, and this is where it's crucial to have, AMMF as part of that discussion, then, that is the big thing. Because once we get beyond that hurdle, then the rest should be easier to work through.
Okay. And perhaps another way of asking the same question to Simon.
Chris.
These centres of ERCP, what do you do? Do you apply? And then once you've applied, who's going to pay for it?
So I think that I echo what Hassan said, that it's involving all colleagues and doing it in a collaborative way so that it's effective. And I think that, talking to your point, John, not necessarily an application process, but making it clear that what tends to happen is these get defined as this is where the unit's going to be, and this is going to be a hub, and this is going to be a spoke. And the people who are practicing in a spoke will immediately assume that means they're excluded from working within the hub. And perhaps not so relevant in surgery, but in ERCP categorically that's not the case, because you could have people in your network that have previously worked in one of the spoke units who come to the hub to undertake complex tertiary work. So whether it's an formal appointments process or expressions of interest, I think that it wouldn't be an exclusive process. It should be inclusive, and you would apply the same expectations and standards to all the people in the network. And also taking I think another major challenge in doing this, being very patient-focused about it, is advantaging one group of patients. So, for instance, the complex hyalocholangio patients in ERCP would have to be careful that we don't disadvantage patients being admitted to hospital with biliary sepsis from gallstone disease. If you're going to set up a service that diminishes the number of units doing ERCP, you need to offer those patients equally good access to ERCP as well, because you don't want to have the result that, because you've centralised your services, someone waits with 2 weeks with sepsis in a smaller unit without getting their ERCP. So you're going to have to plan these networks to avoid disadvantaging other patient groups.
Okay.
Okay, brilliant. Well, that's extremely interesting, guys. Noreen and guys. And that brings us to the end of this session. Thank you very much.